Karen Shelnut is the speech-language pathologist for Alamo Heights Independent School District in San Antonio, Texas. She is in her 25th year as an SLP and has worked with individuals with communication disorders across the age continuum 0 to adult, and focused her career primarily working with school-age children and their families. Karen specializes in working with low-incident, multi-disability populations of students with augmentative and alternative communication assistive technology. She considers the most important predictor of success as an SLP to be the relationship built with every student and family. As an Army wife, Karen has moved and worked across the United States, planting roots in San Antonio following her husband's military retirement. She also volunteers as her district military liaison to support military families and their unique needs. Outside of her practice in speech-language pathology, Karen enjoys crafts, swimming, visiting extended family, and spending time with her husband, children, and many Golden Doodle Scouts. Please help me give a warm welcome to Karen Shelnut.
I have been most excited to be able to meet all of your beautiful children, teenagers, and adults so far with HADS, and I'm learning so much already. I was most excited to hear Dr. Chow yesterday talk about the improvements that we're able to make in the cerebellum in individuals with HADS through therapies. Therapy does work. To me, delayed means different timing and not never or absent. So I hope to focus my time with you today discussing a brief overview of speech services to answer some of the questions that were posed within the HADS community social media forums, and to primarily focus at the end to give you some practical ideas that you can walk away with in order to develop a partnership with your therapy providers, your speech providers specifically, to ensure successful therapy outcomes. I'd like to note that I don't have any financial or non-financial disclosures to report. So one of the questions was, who am I? I am in my 25th year as a speech pathologist, and I've moved all over the country with my husband as an active duty Army officer for 30 years. I have not worked internationally, so unfortunately my information today is based on experience within the United States. My husband retired from the Army a few years ago, right before COVID closures. And so we made our home San Antonio, Texas. I do intend to share information with you today that's fully inclusive of all individuals of all ages with HADS, but by nature of my work setting, I will likely refer to child or student because I work with children, but I don't intend to exclude anyone. As well as use the terms parent and caregiver interchangeably. I really liked how Dr. McDougall used your person yesterday, and I feel like more and more all of you in the community are becoming partly my person as well, so that's a really good term to use. I am new to HADS. I am by no means an expert. I only had one student with HADS, and I feel like, as they say in the autism community, if you know one person with autism, you only know one person with autism. And I feel like it's the same with HADS being such a spectrum that I feel like I only know one person with HADS, but now I'm really getting to know many more of you, which is exciting. I learned about HADS through my student Grant Schindler and his family over the last 3 years of working with Grant, and they have graciously provided permission for me to share some of our history with you today. I want to send a special thank you today to the other special educators that may be joining us either in person or online. I'm especially excited to have some of our team from Alamo Heights here today. Special education teachers, Mr. Elroy Hendricks and Tori Carr, and SLP assistant Lauren Turner. If you guys will raise your hands just to acknowledge our special educators. As most of you all know, special educators have a really special heart for kids, particularly your kids and adults in this community. And I'm sure they equally have a special place in your hearts as well. So when questions were posed to the HADS community regarding all of your many questions, I tried to organize them into 6 major areas. So I'm going to talk with you today about the general scope of speech and language. We do more than correct a lisp or work with stutterers. So we're going to talk about the different areas of communication disorders that SLPs treat, some of the HAD specific concerns, and who are our providers. We'll talk about evaluations and what does a comprehensive evaluation entail. There were several questions about treatment, everything from early intervention options to private versus public school services, and then teletherapy or online services versus in-person. I will touch briefly on assistive technology and augmentative and alternative communication, which is a range of services from no tech, low tech, and high tech. And how do you know what is best for your child? We'll talk about dismissal and what are some of the dismissal criteria to look at, as well as deciding to continue your support with treatment. And then finally, parent or caregiver advocacy. And hopefully you will be able to walk away with some practical ideas. I know when I attend conferences, I really try to walk away with some things that I can implement immediately. So that you will experience success in your speech and language therapy services. So as I read the questions coming from HADS communities, I heard a continuing theme of being overwhelmed, of maybe not even knowing or being aware of some of the therapies and services that are available to you. This is my student, Andrew, and his mom, Ursula. From 2008, I was 8 years into my practice. I was working in a hospital early intervention clinic with the 0 to 3 population, and we would go into family homes with our multidisciplinary team, an educational diagnostician, a nutritionist, PT, OT, SLP, all of the letters. How many letters have you heard since your HADS diagnosis? We all went into Andrew's home together for our initial assessment and completed an arena assessment with Andrew himself. And then we sat around the dining room table with mom, Ursula. We were firing questions at her from the day C, a developmental profile, left and right, question after question, and it was a long morning. As we sat around the dining room table firing our questions, Ursula was staring off into space, almost absent. She recapped their daily routine like a robot. And it got to be lunchtime. My team gathered up their things and got ready to leave. And I put my notebook in my bag as the last one there, and I couldn't look away from the blank expression on her face. Was it guilt? Was it sadness? Confusion? Exhaustion? Was she on autopilot? She was clearly overwhelmed. Maybe that sounds familiar. I paused my bag packing and I looked at her and I said, "How are you doing, Mom?" And it was like she registered with me for the first time all morning. "No one's asked me that," she said. And she took a long, deep breath and she started to cry. I received an actual letter in the mail yesterday from the developmental pediatrician confirming his diagnosis of autism. A letter. I mean, I knew it, but I can't describe how I'm doing. I feel some relief to have an answer, but I don't really know how I'm feeling. I guess this is just the beginning of my journey, she said. I tried to understand the journey that she was beginning, but how could I? I am a mom, but I'm not the kind of mom or dad that you are. I wasn't prepared to understand the medication trials, the doctor's appointments, therapy sessions, tantrums, IEP meetings, successes, frustrations, the explanations over and over to every educator or medical professional, the journey. I know that my journey is nothing like your journey, and I can't ever fully know. I know that I look at mothers like Ursula or Mallory Schindler, and I'm in awe. I knew in that moment that my perspective as a practitioner was permanently changed. I didn't want to be the SLP that came into and out of a child's home for the hour or two that I was there. And I don't want to make a difference now for 30 minutes, 2 days a week in a group therapy session in a school. If I was really going to make a difference, I was going to have to change my approach. I want to prioritize relationships with parents and children to make a difference in your everyday life. And it can go both ways. Parents can prioritize this relationship too. Every single person in therapy is someone's son or daughter, and your providers need your advocacy and your expertise to have the most successful therapy outcomes. We need to have an inside window into your life. That's my goal with you today, to encourage you to bring your therapy providers into the view of your lives to develop a partnership for success. I will bring you back to Ursula and Andrew. So let's try to answer some of your questions. Who are the speech providers and what is within their scope of practice? Again, I can't speak internationally, but in the US, providers include fully certified SLPs, or speech language pathologists. Often in a medical setting, you'll see ST for speech therapist, but our official title is SLP, and their certification will be noted with CCC, which stands for Certificate of Clinical Competence from the American Speech Language Hearing Association, or ASHA. Again, more letters. They've completed a master's degree in communication sciences disorders or a doctorate, passed the praxis exam and comprehensive exams, or COMPs, and completed a year-long supervised clinical fellowship. Then we have CF SLPs, or clinical fellow speech language pathologists, who have completed all of their master's coursework, passed those exams, and is within their first year of practice under periodic supervision of an experienced and certified SLP. They're supervised with both direct and indirect services, and they apply for their Cs after completion of that fellowship. And then the third provider is an SLP assistant, or assistant SLP, noted SLPA, and they've completed a bachelor's degree in communication science and disorders. They are a therapy provider with regular monthly supervision to provide certain practices. They are not licensed to provide certain practices such as evaluations, IEPs, interpretation of data, etc. Parents must be notified when your services are provided by an SLPA, and the services are managed on the caseload of the supervising SLP. You can verify state licensure on the website of your state's licensing agency. In Texas, you can search on the TDLR website, Texas Department of Licensing and Regulation, or you can check for the certification of an SLP as well as specialty areas on the ASHA website with a searchable engine, both of which are included in my references at the end of this presentation. So let's talk about our scope. This is a very large, broad scope. That might be why some of you find a challenge finding an SLP who specializes in a specific area, because our educational background is all-encompassing, zero birth to death. And everything in between. And usually you tend to specialize within your work setting with the type of communication disorders that you work with most often, have the most experience with, and then continue to provide your continuing education in those areas. Some disorders are organic, resulting from an underlying motor, neurological, structural, or perceptual cause, i.e. HADS. Others are functional disorders, and they're idiopathic, meaning that they have no known cause. So the first area is speech production. These are disorders in articulation, or how a child says their sounds, or a person says their individual speech sounds according to the age of typical development. In my references, I have a speech sound development chart that shows which sounds should be mastered by which age for boys and girls. At the end, all speech sounds are expected for full mastery by the end of age 6. So by the time the child has turned age 7. We do consider more than just the speech sounds, like how intelligible is the child? Are there groups of sound errors? In the area of phonology, we focus on predictable rule-based patterns of errors that affect groups of sounds. So a phonological disorder might include final consonant deletion, where you leave off the end of words, or syllable reduction, where you have multisyllable words that are reduced to just one syllable that is simplified. And then motor planning disorders involve the organic or neurological planning for the rapid motor movements of speech. When we talk, we are having a succession of several rapid motor movements that happen almost instantaneously. And sometimes there's a breakdown in the planning because it's so coordinated of a movement and it happens so quickly. Next are language disorders. This encompasses a wide range of receptive and expressive language skills. It's the input and the output, how you understand what is produced to you orally and what you're listening to, and then how you express yourself as expected for your chronological age. We have different areas here. Semantics are your word meanings and your word combinations and use. Syntax is your word order and grammar. Pragmatics, a lot of our HADS kids struggle in the area of pragmatics. These are social uses of language. Again, phonology is the study of sounds. This affects things like rhyming, syllables, segmenting and blending, etc. Morphology is word combinations or units of meaning, like adding a plural S to the end of a word or a past tense ED. And then literacy affects language with reading, writing, and spelling. So we have pre-linguistic communication, things like joint attention and intentionality, and then paralinguistic skills, being able to supplement oral speech with gestures, signs, body language, etc. Fluency disorders are things like stuttering or cluttering, and this is a disruption in the rhythm, the rate, and the prosody of speech. Voice and resonance disorders include disorders of the vocal folds, pharynx, and vocal mechanism. We do treat vocal disorders in the schools with voice therapy, but you're going to most likely see evaluations for voice therapy in a medical setting where we have the tools and instruments to do so. Disorders of cognition include things like executive functioning, memory, problem solving, and attention. In adults, maybe you've heard or know someone with aphasia or dementia. Disorders of feeding and swallowing, again, we see more typically in a medical setting where we're working on oral, pharyngeal, esophageal, and then mechanisms, and then even atypical eating, things like food aversions, working with textures of foods and swallowing. But usually, surprisingly enough, people don't know that speech pathologists conduct modified barium swallow studies. The next area is auditory communication disorders, habilitation and rehabilitation. These are impacted by those that are impacted by hearing loss or have auditory processing difficulty. And then I added this area, assistive technology and augmentative and alternative communication. And it's kind of an overarching area that can be touched by any communication disorder as needed. So some of the communication concerns I'm sure you're already familiar with that may be HADS specific as I'm continuing to learn and read more about this. Like I said a while ago, are the pragmatic disorders or your social uses of language. The lack of facial expressions might impact your nonverbal communication or your understanding of your child or your person's current emotions if they're not able to adequately express that on their face. This might impact peer interactions. They might have difficulty with topic initiation or topic maintenance, understanding of nonverbal cues, things like body posture or when a parent is sarcastic. Now, side note, I have a 15-year-old and he doesn't well interpret my notes of sarcasm either, and definitely does not interpret tone of voice very well. I think that's his selective listening. I added behavior in here because I'm sure you've heard this sentence, behavior is communication. When we are behaving or misbehaving, we are communicating something. Oftentimes, this is a sensory seeking or avoiding of behaviors in the HADS community. I've read a lot about auditory defensiveness. It's too much auditory input. And so I might need to be avoiding that. Verbal perseverations, the term perseveration, meaning that we talk over and over again or ask questions over and over again on the same topic, usually on preferred topics of interest. Or you might have, your person might have difficulty changing topics to non-preferred topics. And then what I've seen in the literature noted as pathological demand avoidance in the more neurotypical, neurodiversity affirming community, we have also termed this PDA for pervasive drive for autonomy. And I like that term. I've written that in several reports. Means the same thing, that the child is insistent on their autonomy and having ownership over that. So in moments where they have some anxiety inducing demand avoidance, demands are being placed and we're trying to avoid those demands. Again, in the area of language specific with HADS, there may be mild to moderate cognitive deficits that affect the language processing, the receptive language processing. And then your attention deficits can affect the quick language tasks, the quick language exchanges, and again, topic maintenance. In the areas of speech, the person may have apraxia of speech. The term apraxia is a disruption in the communication pathways from the brain to the muscles used for speech. And the neurological component impacts that motor planning for speech, resulting in some inconsistent errors. They're not that common motor planning. Things are different. They don't always leave off the ends of words. Or some idiosyncrasies in inappropriate prosody, rhythm and rate, or stress patterns, or even volume, an increased volume or a decreased volume or intonation. And then dysarthria is the weakness in the muscles used for speech. This may result in a slurred or a slushy speech quality, or even the opposite, robotic and choppy. The person's dentition with that high arched HADS palate could affect the articulation when you have the placement of the articulators, that high arched palate, or your just dentition prior to braces, or as the teeth are coming in and developing, can affect how the child is producing speech sounds as well. Before you can begin speech therapy services, you're going to need a comprehensive evaluation. And then you'll need ongoing reevaluation as needed to update a snapshot in time. I have 3 important points that I'd like for you to remember for evaluations. The first is that the more accurate and complete your intake forms or your case history, your parent information, the more complete the evaluation snapshot will be. That is such a key point, and it's really difficult when I receive blank forms written back or one-word answers, because more of looking into the window of your everyday life is going to help me know how to gear my treatment. The second key point is that no single test or measure should be the sole criteria for determining a disability or determining educational programming. So don't take one standard score and call it a day. And then finally, instruments should be administered in the person's primary language, especially if bilingual, technically sound and not discriminatory based on racial, cultural, or regional basis. And I would highly, if you have concerns in any of those areas, discuss the instruments with your SLP that are being used to make sure that you're not having some of that discriminatory basis within the evaluation measure. So an evaluation is that it's a snapshot in time. It can be multidisciplinary, multiple people evaluating the child at one time, or it can be specific to a single area. Maybe we just need to assess in the area of articulation. The reevaluation frequency is going to be determined by insurance requirements or state education requirements, or as needed for gathering updated information. Again, no one tool or test or checklist can give you a complete assessment. It's a putting together of the puzzle pieces that compile the picture for your snapshot. It's a picture in time, just like the photographs of you change over and evolve from one moment to another, so do your evaluations. So it's important when your most recent assessment is when the child is in kindergarten versus when the child is in 3rd grade, and the academic rigor and the academic language that the child is exposed to is changing. You want to have a more accurate assessment of what is expected for their chronological age at that time. The evaluation helps to determine areas of strength and areas of need and should ultimately provide goal planning and recommendations. Again, a really thorough intake or case history is necessary. We want to make sure that the child has cleared hearing and vision screening prior to evaluation. A records review, really thorough, providing related service provider input, so getting information from their OT and especially from their educators who are with them all day, every day. And then we use informal and formal assessment tools. Informal meaning observations in a variety of settings. I like to go in not just to the classroom, but to the lunchroom or outside at recess to observe how are they interacting with their peers, not just how are they interacting with their adults. Taking a speech and language sample and analyzing what their conversation looks like in that sample. And then providing an oral peripheral or oral motor mechanism screening just to make sure that all the structure and functioning is appropriate and functioning for speech. Your formal assessment measures, you've probably heard terms, tests used with your child before, the SELF or the PLS 4 or 5, the Goldman-Fristow. These are all your standardized assessments, but we have norm referenced and criterion referenced tests. So these are the things when maybe in your IEP meeting or your therapy meeting where you're hearing the standardized scores and you're getting that range of the typical bell curve from 85 to 115 and looking at scores that are above or below the standard area. Then it's important that your evaluator is considering the impact of the disorder. It can have a functional impact, it can have an educational impact, but most often I'm looking at the social and the emotional impact. We're talking about communication and how does it most impact the child? It's going to impact them socially, obviously. Finally, you really want to focus in your report findings from the evaluator, the synthesis and recommendations of the evaluation. We want to know what are their areas of strength. I'm sure you're probably tired of just hearing what they can't do. It's a really important question to say, what can they do? What are their areas of strength and need? And then the determination of the presence or absence of a disorder. And then what are the treatment recommendations? Once the child has received a comprehensive assessment, a treatment plan is developed in any setting. In the public schools, this is your IEP or Individualized Education Plan. In the world of special education is much like the Army. There are acronyms for everything. I could provide an entire session on the IEP process, but I recommend listening to Sylvia Farber's presentation this afternoon on top special education tips for parents. Treatment plans are organized with goals written to be SMART goals. You might have heard this acronym, SMART, meaning they need to be specific, measurable, achievable, relevant, and time-bound. In the school system, they're written for 1 calendar year from IEP date to IEP date, but that may need to be reevaluated sooner. But the data is collected and reported on your reporting progress as noted in your IEP or in your private therapy plan. And the data should be reported to you to monitor the progress and to reevaluate the goals as needed. There are so many treatment options to consider. Beginning with the age of the individual, our early intervention services are our birth to 3 population. School-age services in the United States are provided legally and free of charge, regardless of homeschool or private school placement. They are provided by the public school system to individuals ages 3 to 21. We have services for young adults and college students, and then adults, and of course, senior adults. The setting can be private or public and are different in legal requirements as a result. In other words, areas that an SLP may work on in a private speech setting may be drastically different than what qualifies for speech in a public school. The disability determination and the eligibility requirements in public school are mandated by federal education law and the interpretation of that law by the states. Speech can be provided in your home, in a Head Start or state or pre-K program, a hospital, private clinic, schools, post-high school, young adult programs in a learning setting, colleges, university clinics where SLP students or graduate students are learning to become SLPs, rehab facilities, nursing homes, the VA, we're everywhere. And it's definitely a field in high demand if you want to become a speech pathologist. The delivery of services can obviously vary from teletherapy to in-person provision. You can have one-on-one group therapy or inclusive therapy provided within a general education classroom, within a lunch bunch, and can even follow a consultative model. Some of the questions that I read from the HADS community were regarding electing teletherapy versus in-person therapy. I want to share this note. If teletherapy intervention is the only option based on logistics or geographical location, it certainly can be very effective. But consider when it comes to communication that in-person therapy allows for the nonverbal communicative signals that I talked about early, body posture, being able to see what's going on in the environment and how that affects the communication interaction. They might not otherwise be able to be conveyed through a screen. We live in a day and age where our children are already losing components of written communication, i.e. my 15-year-old texter, and talk about letter acronyms with abbreviations for writing. We are already starting to abbreviate how we're communicating in person as well. I am very mid, according to my 15-year-old. The same impact, though, is there with video chatting. Kids or adults who already struggle with communication, verbal or nonverbal, may struggle with interpreting a square on a screen representing, or multiple squares representing people sitting in a room together around a table. They may revert to receive mode, where they're watching TV or videos, which adds additional barriers to the expressive language that the SLP might really trying to be pulling out of the child. And then finally, there seems to be barriers to the speech and, of course, auditory quality of teletherapy, certainly interruptions in the environment. It's the same effect that we had through the COVID years with masks and being able to see the speech models clearly, being able to hear them clearly. And then we use a lot of tactile cueing that helps the person feel the placement of the speech sounds. As an SLP, I might need to touch their face or touch their throat or provide some things with tissues and blowing air to make sure that we're getting appropriate lip closure. Some of that tactile cueing can be lost in the teletherapy environment. When weighing the positives and negatives, think about when you have a phone conversation with an adult, or a video chat conversation, or an in-person conversation. Which do you feel most naturally encapsulates all of the aspects of that interaction? So I'm going to touch on this next area, assistive technology and AAC, or augmentative and alternative communication. Often as a part of an assessment, and definitely as a consideration in every public school IEP, this should be addressed. Assistive technology needs are a part of the federal law that we are to consider for every student. An assistive technology or an AAC evaluation is a separate area of evaluation than your typical speech and language or communication evaluation. Assistive technology is the overarching umbrella. This technology can be used for talking, walking, typing, hearing, etc. It is any technology that is beyond what is already available to every student to assist the child in accessing their education, or for an adult to access activities of daily living. And then underneath the umbrella of assistive technology, augmentative and alternative communication is used, is additional methods outside of oral speech to augment or supplement, or as an alternative to oral speech. So we don't always use augmentative and alternative communication only for our non-speaking clients. We typically use it for speaking clients, sometimes as a way to supplement speech to increase intelligibility or the ability to be understood by others, or to use scripts or to help expand their utterance. So I have students on my caseload right now who use speech generating devices to supplement their oral speech. AT and AAC is a range of tools and a continuum of technology used to create what we call a total communication approach. The goal is not to have only one method of communication, but to use any and all tools that have meaning to the person and are effective for that person. We want to honor and validate all forms of communication. When I am talking with a student who is using what we call a talker or an AAC device, I'm not going to then, if they say something with their mouth or a gesture that I clearly understand, I'm not going to then make them say it with their talker. I don't want to have to write it out if I've just said it to you verbally. And so they need to be able to use all of their tools and techniques to communicate. So we want to validate that. It ranges from no tech, which means it does not require additional equipment. These are things like pointing, gestures, facial expressions, and sign language, to low tech. These are solutions that do not require a battery, things like picture symbols or picture symbol exchange. Core boards look like a communication board, but it's a static piece of paper or board that the child might point to. Writing on even alphabet boards or adaptive keyboards. And then your high-tech options utilize technology. So these are dedicated voice output devices, such as an iPad or using text-to-speech software. And there is an absolute range, and the technology is happening so fast, it's even difficult to keep up with programs. As I've met some of your students, I've seen some programs that I have not had exposure to. So it's a constant continuing education for me as an SLP to keep up with our technology. I will say the expense of assistive technology has greatly decreased over time. Probably 10 to 15 years ago, I wrote a grant proposal for a student to have a Dynavox V, and I think it was $10,000. And now we're able in a school system to provide an iPad, which is $500 or $600 with a $50 app. So that the cost is definitely decreasing. The assistive technology evaluation is a multidisciplinary evaluation. This should not just be conducted by your SLP. Usually the team leader is an SLP or an occupational therapist, and any stakeholders that can help in assessing the child's needs. Often we want to include the child's classroom teacher, their special education teacher, definitely the parents or caregivers, to include regular nannies, physical therapist, occupational therapist, SLP that's working with the child. And I added 2 SLPs there because sometimes your school district may have a separate assistive technology specialist, orientation and mobility specialist, vision teacher, audiologist, etc. You, parents, have a right to request an evaluation in the area of assistive technology, just like you have a right to request any area of evaluation. Put it in writing and put it to the person in charge. Most likely send it straight to the principal. A point for parents to remember: a child is never too young to begin using AAC. We do need some pre-linguistic skills necessary for some of the higher tech solutions, such as joint attention and engagement, but high tech isn't the only option and isn't necessarily appropriate for everyone. Remember that there's a range of communication options to consider. And then the AT solutions are changing over time and with technology advancement. So when school age, that doesn't mean that what they start with might be what they graduate with, or that they even need. I have students that needed an AAC device when they were younger, and then they grow out of and become more verbal and no longer need the supplementation of that device. Remember that if the school team recommends assistive technology, they legally have to provide it for your child to access their free and appropriate public education. So this should be at no cost to you. Your SLP, if you want to own a personally owned device or a dedicated device, your SLP is the person who can assist you in obtaining that, or your assistive technology specialist. And those funding sources can come through your personal insurance, considered DME or durable medical equipment. Your SLP can help you with the reporting and the paperwork needed to justify the need for it. They can assist you in state funding resources or even grant writing. I've written and secured many grants for the individual ownership of a device, and I've never had one rejected. Begin with asking your speech provider for assistance in your funding sources. It's important to own an individual communication device because we view that device as the child's voice. So they need to be able to have it over the summer, over Christmas break, in HEB, when they're at Six Flags, anywhere that they go, that device should be with them. And so it's important that you own it yourself, so that the school doesn't take it back over the summer. We don't want to take away their voice. And I'm happy to discuss any ideas with you after our session if you have specific AT questions or needs, because that can definitely be an hour-long presentation by itself. So dismissal criteria. Dismissal criteria greatly depends, obviously, on the individual client and the provider, the setting, certainly, and then the legal requirements of the setting. And of course, the current impact of the disorder when dismissal is considered. Some of the things that you want to consider in public schools, and this is federally, this is not just Texas. We consider a three-prong approach to eligibility. The first is disability determination. Does a disability continue to exist? If so, what is the impact of the disorder? Is there an academic impact of that disorder or a social emotional impact? And then the third question is, does the student still require the need for specially designed instruction? Or sometimes in your IEP, you might see this written as SDI. Not just can they benefit, because all students can benefit, but do they require? So use those words when you're advocating for services for your child. The child requires specially designed instruction by a speech language pathologist that isn't necessarily otherwise provided by their general education teacher. A general education teacher doesn't have the specific training in order to help teach the child how to appropriately place an R. Have you ever thought about it? If you were going to try to teach your child how to say the R sound, what do you do with your mouth? So that does take some specific specialized instruction. And then in any setting, you want to consider how long has the individual received speech therapy services? What service delivery models have been attempted? Has the child or person mastered all of their goals? And are they showing a continued rate of progress, or has there been a plateau for some time? And then what level of support does the individual need to be successful? Is it something that requires a lunch bunch and is least restrictive, or even a consultative model, or do we still need some individual therapy time to work more specifically on a skill? And then finally, you want to consider the continued impact of the communication disorder on their activities of daily living. So this is the area that I'm most excited to get to talk with you about today. You are the expert on your child. You know what makes him want to communicate. You know what makes her feel secure, what she likes or doesn't like. You know what your child is interested in and what makes your child upset. Helping your child's providers know the most functional areas of communication for your specific person is needed from you, their biggest advocate. So let's talk about some ideas about how to do that. The first, I've mentioned several times, is really providing as much information as you can through that window into your life for evaluations. Connect your provider with HADS presentations. And or HADS information. I'm going to make a little bit of fun of Dave Schindler today, because when I first heard of HADS 3 years ago, Dave is the master of emailing a lot of information, and he probably sent us every resource there is on the internet about HADS. And as a therapy provider in a school, I was overwhelmed by that information because I had never heard of HADS, and I needed to know, what do I need to know so that I can get started with my student today? Most likely your speech therapists in a school setting probably have anywhere between 50 to 90 students on their caseload of all varying ability levels. And different communication disorders and different etiologies. So give them information about HADS. There is a sheet for HADS information in the schools on the HADS Foundation website, but try to make it abbreviated. Help train your school personnel on your child with the abbreviated information and request that it is required in the IEP. There is a part of the IEP that says, is additional training required for your child? And every single HADS parent out there, I can't say this enough, the answer is yes, because your team has likely never heard of HADS. And how does it impact their communication? How does it impact their toileting? We need specific training. So Dave and Mallory, this is where I'm going to cheerlead for them, took it a step further because we talked about that. And I was like, I really need something more like a one-sheeter. I need like the bullet point information. They put together a little PowerPoint presentation, and we have it required in Grant's IEP. And we meet every year with the new team before school begins, and they are the experts on HADS. They are the experts more specifically on Grant. So when I first met Grant and I thought what I was seeing was a seizure, was more of his stimming. When I saw his eyes rolling back, I saw his hand flapping, he was laying on the floor, I thought that was a seizure. So they embedded in their PowerPoint an actual video, a few-second video of what a seizure looks like specifically for him, or what does his stimming look like specifically for him. As an educator, that is so tremendously helpful. I wish I had a PowerPoint on every single one of my students. We need it, we want to learn about it. Communication has to have meaning to the child or for the adult in order for them to experience success. I can't stress this enough. We can skill and drill WH questions all day long, but for Grant, if it isn't about the Amazon delivery truck or tornadoes or trains or the car wash, it's probably not going to have a lot of information. So if we're working on how to answer who questions with a person for an answer, I'm going to be asking who drives the Amazon delivery truck. It's got to have meaning and be meaningful for him so that he has buy-in. And also, I'm a fan of the Amazon delivery truck. If the individual has a specific need in a specialization area, you want to look for an SLP who specializes in that area. Start with your school SLP and ask, is there another SLP in your district that specializes in assistive technology or in feeding aversions or in stuttering? Oftentimes, SLPs have a tendency to specialize in their main areas of interest, but also in the areas that they have a lot of opportunity. So if you're in a place that doesn't have a lot of AAC users, likely your SLP is not getting a lot of repetitive experience with the different communication apps that are available. So ask for a specialist or look on the websites of the program that your child or adult uses. So Tobii Dynavox has a registry, LAMP has a registry. So if I'm a LAMP trained therapist, I show up on that registry as being somebody who specializes with that program. Snapchat, they all have required partners in their on their websites. Think through the goals as you're developing goals for your child. You are a stakeholder. You don't want to go into the IEP or your therapy planning sessions and be in receive mode and have them only tell you what the child needs to work on. Because remember, you're the expert. You know what your child needs to work on. So you want to work on things that are important to your everyday life. Do they need to learn how to make an introduction? Do they need to learn how to effectively answer the phone and ask who's calling? Do they need to be able to have an exchange at the HEB register when they're told, no, you can't have that candy bar? Suggest a variety of communication methods for therapy. This is a win-win situation when I incorporate phone calls or FaceTiming with grandparents. It's such a great opportunity for the child to talk to somebody who is familiar with communicating with them. And they're used to being able to have the appropriate wait time. And grandparents always love it when we call them during the school day and have those kind of interactions. But they need to be able to practice other communication rather than just in-person communication. With teenagers, work on texting, what's appropriate, what's not, or how do I initiate when I want to go hang out with a friend. And then practicing real life work scenarios for adults. I thought about somebody who might be a greeter at Chick-fil-A or Walmart, and how do you respond if somebody's not having a good day when you greet them? So some practical things that they can do in their work environment. Request video modeling. This has been extremely successful for me as an SLP. Parents eat it up when I send them videos because they're seeing how I'm working with the child and targeting a specific skill, and then they're able to implement that at home. Of course, we have to make sure that it's HIPAA and FERPA compliant, but it takes no time to get a 60-second video to be able to send to say, this is how I'm working on topic initiation with peers. And remember that in the therapy environment, sometimes it is more restrictive to be in a therapy environment, even one-on-one, than it is to practice in an inclusive setting, to practice a specific skill, because even if they're in a group in therapy, they're more likely with other students who are also language impaired. So we want to practice with typical neurotypical peers that have typical language skills, to be able to see what that peer model is and how peers typically react. So as we're generalizing and maintaining a learned skill that we've already worked on in the therapy environment, suggest to your team, maybe it's time to start incorporating some lunch bunch where you go into the classroom, the lunchroom, and practice talking around the lunch table with the other kids. And then videos obviously go both ways. Take a little 60-second video of your child outside of the therapy setting, share it with your SLP. This is really beneficial to see what happens. Sometimes parents say, well, I know he does that for you, but with me, he does this. And that's because you're mom and dad. Just like I expect my children to behave in a certain way when they're not with me, but then when they're at home, it's definitely a different way because they're seeing what they can get away with. So maybe your therapist can be able to have that insight and watch a video from you and your interaction with them to make some suggestions of different ways you could reframe something that you're working on. Pardon me. And then finally, incorporate a variety of communication partners, both known and unknown, to practice those therapy skills outside of the therapy setting. I like to call this walk-in talks. Pardon me. And about once a month, my students and I go on a walk and talk around our campus. We go to the front office, and maybe the student is working on providing safety information. This is something important, and I think with maybe our younger HADS kids, being able to say answer the question, what is your name? Where do you live? Who is your teacher? What is your phone number even? Trust me, they can know, and they can use their communication devices to be able to share that safety information. And so we'll practice. We'll go to the front office, and I'll have the ladies in the front office say, oh, I need some information for the computer. Can you tell me where you live? And things like that. And that, in the case the child gets away from you, we want to be able to practice those skills. So on our walk-in talks, other than just with me, I want them to practice with unfamiliar listeners as well. So practice outside of the speech therapy setting, and these are things that you can do at home. Practice not answering for them to see if you were at HEB and they were to get separate. I'm being very Texas here, maybe Kroger, and they were to get separated from you. You want them to be able to generalize and maintain that skill. So remember Ursula and Andrew? Andrew just graduated from high school, class of 2024, and he wants to develop a YouTube channel showcasing his aspiring master builder techniques with Lego sets. Ursula and I have maintained a friendship and a relationship through the years since that day at her dining room table. She too was an Army wife, so geographically we've been separated for many, many years. But she credits Andrew's success on the relationship built with his therapists from multiple disciplines. And I credit her advocacy for her son. She is a fantastic advocate. We've often looked back and talked about that day. I asked Ursula, if you could go back to Ursula in 2008, mom to Andrew, age 2, on that day that you received the letter with the diagnosis, what would you say to her? And these are her words to herself, and I asked if I could share with you and take the liberty of some small paraphrasing. She says, stop and breathe. Everything will be okay. Go with your gut. More times than not, it is right than it isn't. You know your child the best. Will it be easy? Absolutely not. But getting to graduation was so worth it. Your son is a happy, extremely funny, kind, and loving kid. Always remember that he is a kid first. He has a diagnosis, and sometimes it's hard to discriminate, but he is not his diagnosis. He is Andrew. I would do it all over again. Would I do some things differently? Possibly. But one thing I would never change is advocating for him. Never take the answer of no. He is strong, he is capable, and he is going to do great things. As I've walked on this journey, I never thought this would be our path, but I am so glad that Andrew has been my tour guide. He has proven that hard work and perseverance is that much sweeter when he reaches a milestone. Just because our kids don't follow the standard milestone chart doesn't mean that they're never going to reach it. It just means that when they do, we celebrate that much bigger. Celebrate them big every step of the way. Some of the references that I have here at the end that you might want to go back to looking at are the Texas Department of Licensing and Regulation and ASHA, if you need to check for certification or licensure. The communicationmatrix.org, I didn't touch on this a minute ago, but I want to talk about it now. I highly recommend as a parent that you utilize this tool. It's free of charge. Go to communicationmatrix.org. It will help walk through different questions for you as a parent. Is your child able to do this? Yes or no, or yes, they fully mastered it. If you're not sure what the question is asking, it provides video examples of what they're looking for. At the end of this little assessment, it gives you this beautiful color printed chart, and it has separate questions for providers or special educators. This communication matrix gives you an idea of where the child is in the functions of communication, meaning, are they effectively able to protest? Are they able to request? Are they able to reject appropriately other than behaviorally? To be able to look at where they are, and then it gives you a really good idea of where should we go next with goal planning. The SLP scope of practice and the ASHA practice portal go more into depth if you have specific questions about any of those areas that I talked about for the various communication disorders, articulation, phonology. Maybe you have questions about voice. There's a lot of information there. The articulation sound development chart is where you see the development of speech sounds up to age 7 and what should be expected for your child's age. And then, of course, the Understanding HADS education packet was a great reference for today's presentation, and you likely already have it memorized. Does anybody have any questions that I can help with?
What are your thoughts on using both medical and school-based speech? Our SLP at the hospital clinic recently suggested doing a few months of therapy, I think, and then taking a break. We have done both school, home, and medical since 5 months old and are feeling like, based on her current communication level at 4.5, that we may be ready to take a break from medical model. How would you determine readiness of the child for this?
I think the more therapy opportunities that you have and can use, the better. Also remember that they're kids. And so there's a time where if they're school age, they've been in school all day, and then likely they have ABA and they have OT and they have speech. And sometimes they just need time to be a kid. And as I need time to be able to relax in the evenings. So if you have multiple therapy options, being able to combine therapists from different settings, the number one thing that you need to request of those therapists is that they collaborate and communicate with one another so that they're being able to target the same kind of goals and objectives and in the same way, particularly if you're using a communication device, because you don't want two different people programming in different ways or changing the order of the communication device. So it's necessary and imperative to have that collaboration between therapists. Yes, ma'am.
Hi. First, thank you so much for this presentation. I thought
Sure.
this was fantastic.
Thank you.
My son, I just cannot advocate enough for how wonderful the AAC device has been. My son has had it since he was 2 years old, and it went through lots of phases of blabbering and gibberish and just pressing whatever buttons. But now he is a pro, and it taught him to read. A pro, you're right.
Yes, Felix, I got to chat with you last night at the pool. He is a superstar and he knows the weather.
So huge advocate for the AAC, communication devices. My question for you, and this is a little plug for Minnesota, where we're from. There is a fantastic conference in Minnesota called Closing the Gap. I went to it last year. It's what's new in assistive adaptive technology. There's about 1,500, 2,000 people that show up every year, and it's free to parents of kids with medical complexity. So strongly consider going to that. And I would love for you to come present at that. I think that would be just an amazing experience for everyone there.
Thank you. There are several options like that across several different states. I'm not sure what international options there are. Again, I can only talk to the US. But I attended a camp in Colorado several years ago called Talking with Technology, and it was a fully inclusive camp of all users of communication devices, and they were ziplining in their wheelchairs, and they were fishing, and they were using waterproof communication boards in the pool. And what they did was they had camp counselors that helped them do all the typical camp activities and give them all the pizza. And then they had SLPs that went with them throughout the day that worked on all day long, working with their communication device. So things like that are available. I don't know about the cost of it, but that one was within Colorado. So there are lots of opportunities out there. There are also state organizations. I know in Georgia, it was called GPAT, Georgia Project for Assistive Technology. Texas has one at the University of Texas, but there are lots of state overarching assistive technology resources, as well as libraries where you can borrow and trial devices from. Pardon me.
All right, we have
Thank you.
another question from the chat.
Yes.
How old a child should be for starting learning a second language if he or she is having some communication disorders?
Bilingualism is fantastic, and I don't ever like it when people want to steer away from it. It's important if your family and your home culture is to be bilingual. Anything that helps that child to communicate is better. I used baby sign language, American Sign Language with my own children. And being able to have an opportunity to communicate in any language is better than being frustrated with not being able to communicate. So as early as you want to introduce it is great. There is a time where, like, our school is a bilingual school in that we have Spanish and English classes at every grade level. And if a child has a language disorder, we want to pick a specific language for the academic language based on the evaluation, making sure that we're considering a language difference versus a language disorder. So if the child has a language disorder in their home language, we're going to want to be focusing on the home language for the academic language of choice. Yes.
This might be a stupid question, but
There are no stupid questions.
we live in a very small community, very small school district, and my son only gets about 10 minutes every couple of days for speech and physical therapy.
Mhm.
Is that normal, or should I request longer? Or
So there are a couple of answers to that. Depends on what we're working on. There are some models that are very quick intervals of time. For example, we have what we call a quick RTIC model, where if we're working on maintaining a certain skill that we've already worked on in the small group, we might do 5 days a week for 5 minutes, where you can get up to 100 trials in 5 minutes, but it really depends on what the child is working on. So if he has more communicative needs, likely he needs more therapy, and I definitely recommend advocating for that. In the special education world, the way that we determine speech therapy time placement, or the way that I always say, is our present levels of performance. What the child is able to do now determines our goals, and our goals are what determine placement. So if you have 4 or 5 speech therapy goals, I don't know how you can achieve that in a 10-minute time increment and be able to hit it enough times to master that skill within a progress reporting period. So I always say, where we are now drives goals, and the goals drive the placement. So go back to the goals. What does he need to work on? He or she need to work on, and then what amount of time do they need to be able to effectively have teaching moments and learn that skill, and then to practice that skill? I have a question. Okay, yes. Back here real quick, and then
Hi.
I'll come to you. Okay.
Hi, so we live in the UK, and my daughter, she had feeding issues after heart surgery. So we were given a speech and language therapist who helps with that.
Yes.
But we would have to go to someone else for the communication side. And at the moment, we requested it, but they're saying that she's too young. So she's going to be 2 next month. So when would be a good time for us to start? Like, what advice would you have for us to advocate for her?
The earlier the intervention, the better. I mean, if she's 2, that's, to me, in the US, I can't speak to the UK, but I would want to get her in private services as early as possible.
So we should do that privately, because they wouldn't offer that to us on.
I don't know about the offering specifically in the UK, but yes, I definitely recommend that you advocate as early as possible, because the earlier we can begin working, the more progress and opportunity we're going to have, especially prior to school age, when we're starting to transition into more academic focus.
Thank you.
Sure. I think we have a question up front.
I think, do you have something you wanted to say? Okay.
No?
We
Okay.
do have another one on the chat. Any advice on assessing a school district, county, special ed services?
Can you repeat the question?
Any advice on assessing or accessing a school district, county, special ed services?
So start with the special education director that should be able to help you understand what the makeup is in the school district. For example, in our school district, if you are a private school or a homeschool student that lives within our area of residency, then the services are required to be provided by your local school district, even if you're not a student there. But then if your student is enrolled in the public school, begin with the child's teacher. Say, I have concerns. Let's talk about getting a communication evaluation. Let's go ahead and start with an evaluation. Parents, you have a right to request an evaluation at any time. You don't have to wait for a teacher to make that recommendation. Any other questions? Thank you so much.